Okay, so we're going to move on to STIs, part 3, risk factors and transmission. So general STI risk factors, groups with the highest rate of partner change are at highest risk, adolescents and young adults, or just depending on what social norms people have. Lifetime number of sex partners, intervals between sex partners, concurrent sex partners, these things all can increase risk. Having partners from high prevalence groups also increases risk. I'm going to move this a little bit. Thanks. Generally greatest in early infection, peak genital shedding and infectivity. Depends on the average number of new cases generated by an infected person. Barrier contraceptive methods, condoms, diaphragms that decrease efficiency for organisms transmitted primarily between the male urethra and the cervix. And long incubation periods complicate diagnosis. And you can see in the figure here the different incubation periods for each pathogen, and it's really all over the place. And some end up being very long. Yeah, so like genital warts, 90 days. It's a long time, and it's possible that you're shedding viral particles at that point anyway, and transmitting it to your partners. STIs are impacted by the microbiome, so basically the vaginal flora of bacteria, and sort of different microbiome profiles can increase risk for STIs, and different microbiome others can decrease risk. It's very, very complicated. Mucosal surface is critical for physically excluding pathogens. So depending on vaginal dryness or lack thereof, transmission could be impacted by that. Provides support medium for other host defenses, isozymes, antibodies, etc. The vaginal flora itself prevents STI colonization for some profiles. Douching, spermicide, antibiotics may adversely affect the vaginal flora and thus raise risk of transmission. Major efforts in HIV research to modify flora and thus decrease transmission risk. So this is an important angle of research right now. So when we talk about transmission dynamics at the population level, there's a core population of people who are at the highest risk and from which transmission regularly occurs, and there's a bridging population between them and the general population. So you might think, just as an example, men who have sex with prostitutes, for example, male or female, form a bridge between that group of people, that high-risk group of people, and the general population, for example, their spouses at home. So this has implications in how we approach the research to STIs, and also how we would approach public health interventions to STIs. What populations do we target? Obviously, the general population might be greater than the core population, and so we might want to focus on the bridging population to prevent transmission in the general population, or we might just go to the source and focus on the core population. So the role of core groups, population subgroups disproportionately affected by STIs may be endemic reservoirs for STIs in the community. So for example, neighborhood drug markets, socioeconomic status, all these things, all these different factors about this high-risk group might make them a core group and thus the source of transmission. Another subgroup might be bridging the two. There's barriers to STI control at a community level. So for example, family structures, poverty, labor migration, low social status of women worldwide, risky sexual behavior, little control over decisions, lack of power to negotiate with partners, limited healthcare services available to people in core groups, lack of access to healthcare facilities, and also I think just religious stigma, social stigma, all these things can present a very serious barrier to controlling STIs. Policies that focus purely on punitive measures rather than actual public health prevention methods can lead people to not come forward when they're infected, for example, and seek treatment. Potential solutions, economic and social policies that decrease family separation, may decrease vulnerability. Other economic opportunities for women other than sex work. Many places, like for example in Western Kenya, where I've been, there's not many ways for women to make money, and women can't always depend on men to bring back money from fishing activities, for example. And so sex work is an attractive option for many women, just because they need money to support their children and themselves. Improve healthcare services, better prevention and care. Education on STI symptoms and complications, and promotion of improved healthcare services, increased use of services. So how do STIs disseminate? Remember we talked about R naught, the number of cases that arise out of every single case of an infection. When we talk about STIs, it's a little bit different than talking about like vector-borne disease or these things. So we have beta, the efficiency of transmission, times the rate of sexual partners change, times the duration of infectiousness. And this is sort of a simplistic model that gives us this number. Because more opportunities to, more efficient pathogens will transmit, wider when a person has more partners, and when the duration of infectiousness is longer. And when the duration of infectiousness is low, obviously we'll get less cases out of that. Controlling STIs, we want to decrease the case reproduction ratio. That's our goal, is to reduce the number of cases that arise out of each case. And these include barrier methods and vaccines to reduce the efficiency of transmission itself, condoms. BCC, promote safer sexual choices, so getting people to have sex with fewer partners. But obviously this is a non-starter for sex workers themselves. Case and partner management to shorten the duration of infection, efficient and rapid treatment. STIs and HIV, strong epidemiologic association between HIV and other STIs, 2 to 5-fold increased risk for HIV among people with other STIs. So early studies about STI-HIV infection led to promotion of general STI control as a crucial component of HIV control. So when we talk about sexual health, we're talking about general health and the prevention of more serious conditions like HIV. So I just want to point to the CDC website. So if you Google STI prevention methods, this is the site you'll see. And I just thought this is somewhat interesting because of the order. It's not alphabetic. And so the first one is abstinence, which I thought was interesting. Next one is vaccination, reducing number of sex partners, mutual monogamy, depending on if you read this left to right or up and down. And the final is used condoms. I really found that interesting. And this is sort of an example of where politics sort of has come into the discussion of STIs. And obviously, we would think that abstinence would be an effective route to do things like control STIs. But the reality, I think, is, and this is my personal opinion, is that abstinence is unrealistic for most humans. People have always had sex. They will always have sex. There's really not much we can do about it. And it's absolutely ineffective. These abstinence messages are absolutely ineffective for groups at highest risk anyway. I mean, telling a sex worker to be abstinent is ridiculous. She or he is not going to do that. And telling a person who frequents sex workers to be abstinent is also a non-starter. So I found that very interesting. Sort of asking you to target the people who are already at low risk anyway. So that's interesting to me. Vaccination, I find this interesting on here because vaccination is only available for a small set of infections, and that's HPV and Hep B. Outside of that, there's no vaccines for syphilis or gonorrhea or any of these different things, especially not for HIV. And so, suggesting that people be vaccinated as HPV is good. Putting this so high on the list of measures to control STIs is very interesting to me. Reduce the number of sex partners. Again, this works really well in low risk groups, people who are prone to have low numbers of sex partners anyway. It might not necessarily work with the highest risk groups. Now, that being said, it might work with the bridge group that we talked about earlier, and reduce opportunities from transmission from that core group to the general population. Mutual monogamy is the same thing. It's not, especially in some cultures, it becomes very difficult. And there's not all cultures around the world practice mutual serial monogamy like we do, or even mutual monogamy. And polygamy is very common in many parts of the world. And having concurrent partners is not out of the norm for a lot of the world. So this is a very interesting sort of message here. And why do they put used condoms on the bottom? I don't really understand that. I think used condoms should be at the top. Condoms have been effective for the prevention of many infections, with some exceptions, like crabs, for example, or diseases that are transmitted through oral contact. Using condoms is one of the most effective public health methods of prevention of STIs out there. It's ineffective for the prevention of infections transmissible by multiple routes. It's fine, but for most infections, condoms is extremely effective. For HIV, condoms is extremely effective. We want to promote people using condoms. Human beings are going to have sex anyway. If they're going to have sex, we want them to have safe sex for sure. So that's sort of my soapbox opinion here. I just found this kind of interesting, and I sort of want to put that out for you to think about. Is how do the politics and the messaging sort of either work to exacerbate or mitigate problems of infectious disease transmission, and sort of keep this in the back of your head when you're looking at even things like on the CDC. What does this mean, and why is this strange, and how can we improve public health messaging? I think that's really the core of it. How can we improve public health messaging to protect the public health? So thank you very much for watching this. We're going to move on to HIV.